Good morning, everybody. I think we can start now. I'd like first to thank the organizer for the nice invitation to be part of this panel. I mean, it's a personal thank you. And I would like now to give you a short introduction on the panel of this morning. We are going to talk about the evaluator's view and some international experiences on HTA and how patient involvement can help bridge the gap between scientific evidence and decision making. I would say, maybe because I'm myself a patient representative, so far patients are the untapped resource in HTA. There's a lot of knowledge and expertise there that could be used better. And we are going to look at how this can be done with the support of our panelists. So I will introduce now the two panelists that are with me. Tammy Clifford from Canada. She works at CADTH, the Canadian Agency for HTA. Tammy is a chief scientist, and I see she has been working on HTA for a good part of her life. Now she has worked at the Canadian HTA agency in different capacity on horizon scanning, but also on patient engagement. And in her presentation, she will go through how the Canadian agency involved patients in the HTA processes. And then we will also look at the Spanish experience with Ana Toledo Chavarri. She will speak also on behalf of Pedro Serrano, and she will bring the experience of the Spanish network of HTA agencies. I will be the first one to speak because somehow I have to also replace one of the panelists that were foreseen in this discussion this morning, Victoria Thomas from the NICE, UK. Unfortunately, she cannot make it this morning because she had to cancel last minute because of reasons that go beyond her power. It's the Cabinet Office who decided to impose this last-minute cancellation to all officials from UK. None of them can attend or speak at any meeting till the elections in June. And so she's very sorry she cannot make it, and we will find a way maybe to send her our greetings afterwards. I will be the first speaker, and then I take the opportunity to introduce myself as well. I'm Valentina Strammiello from the European Patients Forum, which is a European umbrella organization representing all patients. EPF is based in Brussels, and I personally work on HTA since 2015. Of course, I look at all the aspects of HTA, but of course, mainly patients' engagement and patient involvement, and we try to let's say, advocate how patients should be involved in HTA processes. So I will give you a very short perspective. I hope it won't take too long, and maybe we can leave the room for questions and answers after presentation from Tammy and Anna. Okay. So a very brief introduction of EPF. As I said, it's an umbrella organization, and our mission is to ensure that patient community drives health policies and programs that are adapted for the final users and patients. Our vision is high-quality, patient-centered and equitable health and social care for all patients across the EU. I identified here the second goal of EPF, which is to contribute to improvement in health systems and enable equitable access to sustainable and high-quality health care. I think this goal is really suited for this discussion today, because at the end of the day, HTA is a lot about allowing access to high quality and innovative medicines for all patients. My presentation will be around three key topics. So I will give an helicopter view of patient involvement in HTA in different European HTA agencies, and how it eventually should be working. Who and how is involved or should be involved at which stages. I mean, I won't be too detailed here because I'm not a technical expert, so, but I would like to highlight what are maybe the ways patients could be involved in the processes. And also, I will highlight the main difficulties and challenges faced in patient engagement in HTA and what are maybe the solutions to address these issues. So, the starting point for me is how come people with chronic conditions, maybe the same chronic conditions across Europe, get different treatments. So my first reflection go to, of course, to availability and affordability of treatments, but of course the issue that NHS systems are often different. So you can have full universal coverage in some countries, but not in all of them. Also, an issue could be that HTA agencies in some cases are independent bodies, in other cases that they are endorsed by the government. And of course, another point is the lack of a standardized methodology at EU level. This is the effect so far, but we hope in the future it will be overcome. Last but not least, HTA, of course, is a wide sectors, and HTA agencies in Europe don't look at all at the same technologies. In some HTA agencies, the focus is on medicines, and in other on medical devices, or both of them. In others, even procedures, programs. So it's very diverse, and it's difficult to make a comparison between one experience and the other one. Very quickly, I'll go through with some national experiences, and maybe tell me if I'm wrong, but I read that Spain was one of the first countries adopting HTA in the 80s. Can I have a confirmation on that? Together with France. What is interesting about France is that recently the Haute Autorité de Santé started a pilot project to involve patients in HTA, and in fact they invite patients to submit to respond to questionnaires on their treatments, how they cope with their conditions, what's the impact on their quality of life. The problem there is that they've started focusing on selected conditions, and I heard from some patient representatives that patient organizations don't see this as an optimal solution so far. There are still a lot of issues to be solved around this kind of consultation. But of course, as patient community, we welcome the effort they are doing. And of course, there's a long way to be run, actually. Who claims they do it better? We know Germany, they always say they do it better than others. And it's a very well-structured process, and of course they include patients in the process. They have even subcommittees that involve patients, but with no voting rights. What is good is that they try to be as transparent as possible. So even though patients have no voting rights, they can share their views, and if their views is not coherent with the final decision from the assessments and appraisals, they can make it public. So at least this will be considered publicly, and it's I think an important outcome. Of course, the Germany Appraisal and Assessment Appraisal Authority tries, of course, also to involve patients through submissions of comments and submit their evidence. But the problem there maybe is that they have limited time to do it. So in principle, they need to have dedicated people who can respond timely to all these requests. Now we move to another example, which is of the UK, England, and Scotland. They so far are considered those doing better patient involvement in HTA. They have patient involvement units at SNICE, for example. Even in the Scottish case, the Scottish Medicines Consortium, they have established a patient and public involvement group. They have national policies attesting that patients should be involved in the processes. So it's really well structured, but it's not always as well implemented as well as structured. So there are issues here as well, I think. Although we see there are many efforts being done through the involvement of patients experts that somehow try to build a bridge between the agencies and the patient representatives and the patient groups. I'd like to show you this couple of slides, which is, I think it's interesting. This is an experience, an initiative coming from Eastern Europe. This is not about an agency, but this is about a bottom-up initiative that started, I think, last year. It's called Central Eastern Europe Think Tank on Patient Access. And why they built this kind of think tank? It's because in Eastern European countries, there's still lack of resources to ensure patients access to innovative technologies. It's a completely bottom-up initiative. We will see experts, medical doctors, pharmacoeconomists, representatives from patient organizations are part of this initiative. It's led by the Bulgarian national patient organizations, but there are also contributors from Croatia, Hungary, Romania, and Slovakia, and they foresee the involvement of experts from Bosnia and Herzegovina, Macedonia, Serbia, and Slovenia. I think so far this is the most interesting, innovative solution for HTA because it's a completely different approach. It comes from patients and from citizens. It's not a top-down approach to HTA. And now, yeah, of course, maybe you know all of this, but patients are active also at the European and international level. So we try to somehow coordinate the collaboration on HTA through some existing more or less informal bodies. One of them is the HTA network, Patient and Consumer Stakeholder Pool. It was recently established. Another one is of course, a group of patient organizations collaborating with UNETA. Even there, this is really informal. We don't have any formal collaboration, but we are showing our commitment and effort to contribute as much as we can. EPF itself has an informal working group on HTA. We have regular teleconferences. It is just a way to share our views, and share information, because it's very difficult for us to gather information or even to be able to respond to requests coming from HTA agencies or from UNETA. So through this joint work or joint dialogue, we try really to overcome this issue, because for us, capacity, human resources are a big issue when it comes to HTA. It's a big and active sector, so we try this way to solve it. Last but not least, the HTAI patient involvement interest group. And part of this group, there's now also a patient panel. It's a smaller group of just patient representatives. Now I'll move to the second point, which is who and how should be involved at which stages of the HTA. You all know maybe this graphic, so I won't focus too much on this one. The point is, at which point patients should be involved. In our view, they should be involved in the whole life cycle. There's no point where their contribution is more meaningful than others. Consider that patients maybe are not experts, they are not HTA experts, so they need to understand the context where they are involved. If they are asked to contribute to an assessment, they need to have a full overview. And while what most often happens is that they are simply consulted at the end of the life cycle, which is useless to them. So what we say is they should be involved already in the scoping phase, in the prioritization scoping phase, in the assessment, follow-up. But this means that, it shouldn't be always the same patient representatives doing it. There's a different role for patient representatives and patient organizations. What we can build together is a structure where we foresee, for example, the involvement of patient organizations when it comes to ethical aspects or to methodologies, while patients themselves will be involved in the assessment, because of course in that case you need to look at the clinical aspects. But all this is still under discussion, and we are trying also together with UNETA to build this kind of structure and see how it could work the best. But what we need is a bit of also the willingness from HTA agency to contribute to this process. So this is what I just said. Depending on the consultation and on the task that is required, we may foresee different actors within the patient community. Oops. Oh, I missed it. I don't know what I did. So what are the challenges faced in patient engagement in HTA? We have discussed with some of you yesterday. To me, time is key. So what we always ask HTA agencies, please let us know as soon as possible which the topics to be assessed will be, because for us it's important to be able to approach the right patients. It takes time because we are European platforms, and this means that to identify the right patients in a national context, we need to go and to contact maybe disease-specific organizations and then identify in the national context who's the best person for the assessment. I'm not sure whether HTA agencies have completely understood this issue. And so they often come with last-minute requests. They don't provide full information. They don't provide a clear profile, the profile they need for the assessment. And so for us, it's a kind of nightmare. Another challenge is language. We always say we would like to see lay language documents that are accessible for patients and even patient representatives. No matter how experienced we are, still, we cannot take the time to read a 200-pages document. I'm sorry, but it's impossible. So just to make also our contribution more effective, we would like to see summaries written in lay language that we can easily use and also use for dissemination to our patient communities. Another issue is that patients, that's maybe my personal view and maybe I'm wrong, but they often are perceived as a burden or as a passive actor in the HTA process, while I would say they should be foreseen as an ally in the HTA assessment. So they should be as a resource, not just as a burden or as those who take time in the assessment. As I said before, patients should be involved in the full life cycle, and this is because it helps even getting more understanding, a better understanding of the process. It's a learning opportunity for them if they are involved in the full life cycle, even though they are not directly involved, but it's good for them to monitor and to see the evolution. What I heard sometimes from some patient representatives is that, okay, they get involved in the process, but they will never know what's the outcome of the assessment. They will never know how their contribution has influenced the final decisions. So it's important for them to know what happens afterwards, even though there's no direct involvement. Another point is education. We often say, okay, patients to be involved need to be educated, but I would say not only patients, even other stakeholders that are involved in the process need education. They need to be educated to be able to communicate with patients, to find the right avenues to involve them in the process. We have a ZPF program that is called HTA, and it's really trying to fill this gap, educating a group of patients that are now experts, and they are really able to understand the full life cycle of HTA, clinical and medicines development, and we hope these patient experts will be able to be involved in the HTA assessments in the future. Last but not least, I would say another solution to overcome these challenges is to build connections with patient organizations. You can do it. I mean, it's not too difficult because in most of the European member states there are patient organizations, national coalitions that can be there to support you. Just try to identify the national coalitions because they are the bigger platforms, so they will be put you in contact with disease-specific organizations. Of course, this is a bit time-consuming, but I think this effort can be done, and it's just an investment for the future. This is the end of my presentation. So I will now give the floor to Tammy for her presentation on the Canadian experience, and afterwards to Anna.
Great, and good morning, everyone. And I just want to echo Valentina's thanks for inviting me and for inviting CADTH to participate in this. We're very anxious and eager to cooperate with our HTA colleagues. And I think my presentation this morning will show you just how important those reaching out and establishing networks will be. So I always start out with a little disclosure slide, just so people know where I'm coming from. So like Valentina said, I've been at CADTH for the past 12 years. I've overseen the patient engagement file for a few years. I also hold an adjunct faculty appointment at the University of Ottawa, so I sort of have one foot still in my academic roots. And I don't have any other financial conflicts of interest, but I do want to let you know that CADTH is funded by many governments in Canada, so our federal government, as well as our provincial and territorial ministries of health. And very recently, CADDIS drug formulary programs have started accepting application fees from the pharmaceutical industry. So this is simply a fee that's associated with reviewing their dossier. And of course, that was precipitated by the fact that we were getting asked to do an awful lot of reviews, and our funding had been stagnant for about 10 years. So the suggestion was, go ask for fees from the industry. So those don't affect the programs with which I'm involved, but in the spirit of full disclosure, I wanted to let you know that. So a very brief overview of Canada, a really big country and very few people, relatively speaking. So we're spread out across the U.S. border for the most part, and we're not crossing that border right now. Enough said before I get myself into trouble. So in terms of healthcare in Canada, so we've got 10 provinces, 3 territories, and a federal government. We're very clear about who does what, with regulation, so sort of market access of drugs and medical devices being the responsibility of our federal government, so Health Canada or the U.S. equivalent of the FDA. So that merely allows things access to our market. It doesn't necessarily mean they will be paid for, nor that patients will be able to get access to them. Our provinces and our territories are responsible for the delivery of healthcare, and that means they hold the money. So each and every province and territory is able to decide what they fund, which then leads to an issue I'm going to mention in a few slides, because we do have variation in terms of what is covered, and of course variation in how much per capita is spent per citizen in each jurisdiction. Some of our provinces are what we call have provinces, so they have money. Some of our provinces are have-nots, and the desire with the Federation is that we should all be, somewhat sharing in this, but it does cause some political, what's the right word? I think you get what I mean. There's often some dissatisfaction with sort of how the money gets moved around. We do have a universal health system in some regards, but actually it's many systems, and what our system covers is anything that goes on in a hospital. So you're covered there, you're covered for your doctor's visits, but you are not covered for prescriptions that you take outside of the hospital. You're also not covered for dental or vision care, and a whole lot of home care falls outside of our universal coverage bucket. So there's a lot of discussion going on in Canada right now in terms of trying to figure out what we want our healthcare system to be. Our current system got its start before I was born, so that's probably getting to close to 50 years. And when it was established, of course, healthcare looked very different to what it does today. So when people often hear about Canada, they think, oh, you've got a wonderful healthcare system. It's lovely, but it's got its cracks, and so we're not wanting to throw it out, but we know that we need a little bit of work. So here are some stats about just what we do spend on healthcare. So we're looking at about $220 billion annually spent on healthcare. And as I was mentioning to some people at dinner last night, the majority of that spending is going towards hospitals, about 30%, and about 16% going to drugs, and an equal amount going to physicians. I should mention that our healthcare system does cover drugs for those over age 65 and those who are low income. So there is that safety net there. But I think I have a slide that's showing that about a third of Canadians have either gone without or know someone who has gone without needed healthcare because something wasn't covered. So we're getting to that point now where people are having to make tough choices, and that's sort of what has put us into this particular situation. Here's the slide that shows sort of the inter-provincial variation in per capita health spending, and so I won't go into the details about this, but just to show you that it goes from probably a high of 14,000 per person up in Nunavut, which is one of our northern territories, to I think the lowest is just below 6,000 in a few of the provinces. Our northern territories are very remote, and so that certainly adds to the cost of delivering health care for those citizens. I have a little bit of glare here. So what does HTA in Canada look like for drugs and for devices? Well, it looks very different and very opposite to what exists in Spain. So in Canada, HTA of drugs is quite a centralized process. About a dozen years ago, the provinces and the territories agreed on a common drug review. So prior to that time, every province and every territory was doing their own review of every drug that came to market. And as I mentioned earlier, we have our have-not provinces. It's not that they just didn't have money, but they also don't have the capacity to do the kind of work that's required for doing HTA. So some brilliant people came together and said, let's have a centralized process, and that exists at CADTH. So we have a common drug review. We now also have essentially a common drug review for oncology. So oncology drugs go through a separate process, but it is also managed centrally, and every province is still able to make their own decision. So we do the HTA, we have an expert committee that makes a recommendation, fund, don't fund, fund with some conditions. The provinces and the territories make their own decision, but 90% of the time, they're in line. They're in line with the recommendation we make. On the devices side of things, your guess is as good as mine. So there is no formal requirement for HTA of anything that's not a drug in Canada, which means things show up in our healthcare system and in our hospitals without people even knowing about it. I've had hospital administrators say things show up and they go and hide them in a closet, hoping that someone won't use them, and the thing makes its way out to the floor. There is, though, I don't want you to get the sense that we don't do HTA of devices, because we do. CADTH does this, as do other bodies in Canada. So our colleagues in Quebec at ENES do this. Our colleagues in Ontario at Health Quality Ontario do HTA of devices. And we also have a lot of academic and hospital-based groups that do medical devices, procedures, tests, you name it. And so the challenge for us is how to coordinate that so that we're not duplicating each other's work, and so that we're able to share that information, again, with the hope of maybe speaking to a common system. So what you're able to get if you live in Newfoundland, could that also be the same that you could get if you live in Alberta? So a little bit of a hodgepodge there in terms of the medical device HTA. So CADTH, as you probably know, is independent, and so even if there were an election, I could still be here talking to you. At least I think I can. I've been through a few elections in Canada. So again, we sit arm's length from government. We're very much funded by government, and we're there to support the decisions. We're not the decision maker, but we're doing our best to bring as much evidence as possible to those eventual decision makers. We're based in Ottawa, so Canada's capital, although we do have employees around the country now. We're approaching 200 employees, and we contract out a lot of our work to our academic-based colleagues. Again, anything that falls into that healthcare gamut, drugs, devices, tests, programs, you name it, we're looking at it. Perhaps with the exception of vaccines, that rests with the Public Health Agency of Canada. And we also have not started doing any work on regenerative medicines. Perhaps that's because they haven't quite come to our regulator yet. So we're ready for them when they come. So as I've mentioned, we do a whole lot of reviews at CADTH, and so the drug formulary, the drug reimbursement programs are probably our most famous or infamous, depending on whether you like what we do or not. Again, the oncology process is separate, and that's because it was stood up separately and afterwards and kind of came into CADTH a few years ago. And then within the programs that I've been closely affiliated with, we call these our health technology management programs. So in there you have everything from horizon scanning, environmental scanning, rapid response, and then our traditional health technology assessments. We've also brought in an early scientific advice program within the past couple of years, quite analogous to what goes on here in the EU. So here's a quote from our strategic plan that's currently in existence, and one of the objectives clearly says that CADTH is to embrace evolving successes in patient engagement practices in HTA. And so I've given the web link there for you to look at in case you're curious. I do want to point out the fact here that this is specific to patient engagement. Public engagement does not appear. And that was, I'll say it was intentional. We brought this forward to our board of directors to be both patient and public. And the board felt that in order to do things well, you might want to focus on one at a time and kind of get it established before kind of boiling the ocean, if you will. So they've said, get the patient processes nailed down, do that in a leading way. and then we can consider the public or the citizen engagement later on. So again, that was intentional, but I wanted you to know that it's not like we haven't thought about the public aspect. We have. It's just, I think it could consume our entire agency if we wanted to get all 36 million Canadians to understand the processes, so the medicines development processes, and have them be able to participate in a way that is truly meaningful. So why do we do this at CADTH? And this is a quote that we like to show. And it's an important quote because it does speak to the very unique value add of having patients engaged in our work. It used to be, it was just the right thing to do. So this is a bit of an evolution for us because when we first started engaging patients, I dare say there were people in the room who thought this was not the right thing to do. So we've evolved, and I think most of the people involved in our work, so not just our employees, but our committee members, believe in this. But I would be lying if I said there still aren't people who are wondering why. Is this important, and does it make a difference? And I'll get to some of that in a few slides. So again, this is why it's important for us to do it. So again, we've recognized that this HTA ultimately affects patients and their carers. And so, you know, we need to listen to the people who understand their condition the most. They also are able to tell us things about the real world effectiveness of the current treatments. So we're not going to get this from the literature. Let's speak to the people who are best suited and best placed to weigh in on this. So CADTH is a signatory, if you will, to the HTA patient and citizen interest group of values and standards around patient engagement in HTA. And if you want to go and check it out, I've given the web link here. This is a really seminal piece of work that engaged a lot of people over a lot of time, and it's very thoughtful. So it speaks to essentially 5 reasons for engaging patients in our work. So again, relevance, fairness, legitimacy, equity, and capacity building. So that education component is there. And this is what we believe in. This is what is posted in all of our researchers' cubicles so that they're able to look at that and remind themselves of this. You know, this is what it's all about. It's being able to support decisions that affect patients. So how do we do this? Well, we do it in a whole bunch of different ways at CADTH. So our board does have public members, and some of our committees, all of our expert committees have either patient or public representatives. So we have them there. They are full members. They have every right, as do our economists, our ethicists, our clinician members. We also ask patient groups to provide input, templated input, into our drug and device reviews. We're also speaking with patients in our early scientific advice process. We have an umbrella group, a committee. We have a lot of committees at CADTH, but again, our patient liaison forum is a committee that is specific to us being able to share information with our patient group members, and for them to also have input into our strategic direction and any process improvements that might be required. We also meet with patient groups annually, usually in the fall, and have an open session with them, telling them about what's changed, what could be changing, and just to ensure that open and public dialogue. Our annual CADTH symposium, which we held just earlier this week, has also been had the patients included designation for the past, I think, 2 or 3 years, and that has been very important. I think this particular year's symposium had a number of patients involved, and they really appreciated the opportunity to not just sit in the audience, but to be up on panels, to have poster presentations, to be able to ask questions of anybody who was in attendance. And also, many of our topics, particularly for the big device topics, we have an open call. So anybody, in Canada, in fact, in the world, who wishes to submit a topic idea to us can do so via our website. So that includes patients, includes clinicians, and industry as well. So we're engaging patients in a few different ways. In terms of our drug review process, which is probably the most, the one that we've been doing the longest, we've worked with our patient groups to get the timing right. So just as Valentina said, you need to provide advance notice that these things are coming, and then let people know how long they have to do this. So over the years, we've been able to get into a rhythm where we're notifying everyone when we think we'll receive a submission. We'll confirm that when we actually do receive it, and then we're notifying the patient groups as to when their input is expected. We've also gotten smarter over the years, recognizing that many of the submissions that we're getting are for drugs in the same disease category, for example, rheumatoid arthritis. So rather than having a patient group, submit 5 different inputs to us over a 3-year span on the same condition, same existing treatment backdrop, we take the earlier submissions and go back to the patient groups and say, does this still work for you? Have things changed? Because again, we've recognized the burden that a lot of this engagement is placing on people who are sick. They might be carers themselves, and they're engaged in a whole lot of activities. So we're wanting that engagement to be meaningful, but we also don't want it to be burdensome to the patient groups. The input that we receive from patient groups goes to our expert committees. And so either our patient or our public members will present that as part of the evidence package. And I think this is really important to say. We consider the patient input to be evidence. It is not an add-on. It is not something else. It's evidence. And it actually gets posted to our website along with our clinical and our economic reviews. So that whole package is there for the world to see the evidence on which a recommendation was based. And then because we're not the decision maker, we also share that patient input with the final decision maker, so the public drug plans. Again, wanting to be respectful of the requests that we're making to the patient groups. So can we share it rather than have the public drug plans ask again? Absolutely. I wanted to share this particular, I think they call it a word cloud, the younger people in my organization do. I don't do those things, but what I'm told is the size of the font represents the frequency of particular words that have shown up. So a few summers ago, we had a university student join us, and she took a look at 30 submissions that had been received, patient submissions that had been received for our common drug review. And she looked at all those submissions and effectively did a qualitative analysis. And we were looking at the outcomes that patients said mattered to them. So these are the words that showed up frequently. You'll notice quality of life, ease of adherence, fewer side effects, symptom relief. You're not necessarily seeing things like, my blood pressure went down. Right? Or I could do the 6-minute walk test. So this is giving you a sense of where this slide is going. So when we took a look at all the patient input for those 30 drugs, and we looked at the outcomes that patients said were important, you'll see that there were 119 things that patients said mattered, outcome-wise. CADTH included 75% of those in our review protocols. So definitely room for improvement there. If I could see the next slide, I would say, which one's that? So that is our expert committee deliberations. So again, you'll see a drop off. So what patients have said matters. What gets included in the CADTH review, we're already down to 75%. What does the committee consider in its deliberations that we record? We're down to 56%. But then we went back to the clinical trials that get submitted to us to review. And there, only 50% of the time were the outcomes that patients said mattered even captured in the clinical trials. So I think this supports Valentina's point about having patients engaged upstream, even in terms of the initial drug development pathway, about here's what matters to us. Clinical trialists, industry, you need to measure what matters to us. And I know that there's challenges in that. I completely understand that. But for us at CADTH, this was quite a pivotal moment to say, you know, this could be part of why we don't recommend everything, because the data that we get are not speaking to what matters most. So we're hoping to be able to update this particular review maybe this summer if I can recruit a student. So stay tuned. I wanted to share this with you as well. It's actually hot off the press. It came out only yesterday, and it's from a blog in Canada called Healthy Debate. And I've given you the link there so that you can go and check it out. But effectively, it's speaking to the need for the pharmaceutical industry to pay more attention to patient engagement. Again, speaking to measuring the outcomes that matter most, talking to patients about what's not working with existing treatment. So I'm just putting that there to say this is a very hot topic in Canada, and I think it's going beyond simply how do we do this better for HTA. On the devices side of the business, it's a little bit different to our drug review processes, and it's because the work that we do for HTA isn't so much about single technology assessments. So it gets a little bit more challenging to find a patient group, let's say, to respond to, okay, do we need to buy a 7 Tesla MRI? Well, who's that MRI going to be used for? It's going to be used for a lot of different people with a lot of different conditions. So we've had to think about how to go about engaging patients in this particular work. So we do interviews. So we're getting into a little different space with our medical devices work. So doing qualitative research, interviewing patients, looking to the literature. The sociological, the anthropological literature actually does contain quite a bit of information about patient experience, patient values, patient preferences. I think it's because HTA has been dominated by quantitative folks like epidemiologists and economists. We just didn't even know that this stuff was there. So once we opened our eyes, we found out, yeah, there is quite a bit of evidence out there. And I think this can also help with the issue around burden. So we look to the literature first to find out what's out there, then we go to the patients to validate or supplement. So we're tweaking that process. As you can see, I've listed a few of the projects that we've done engaging patients at the bottom of the slide. And so these are all very different. I mean, the first couple, you might be able to go and find very identifiable patient groups. Sleep apnea, yeah, maybe too, and maybe involve the carers or the wives listening to their husbands snore all night long. And then dialysis. So we were looking here at moving dialysis from out of the hospital to the home, again, because of our rural, remote, and northern communities. So our expert committees I've mentioned have patient or public members. If you wish to ask me why some have patients and some have public, that's a really great question, and my answer is, I don't know. It's just the way these committees grew up, and as you can appreciate, trying to change things gets very challenging. Scientific advice I've mentioned, so this is the early dialogue process, and we do engage patients as experts. We pay them for their time, again, as we would any other expert. And sometimes, though, it is challenging because this is quite it can be an issue for confidentiality and non-disclosure, but we've been able to work through that to date. This is our patient community liaison forum, and it is it's still a very small group, and I think this is one of the challenges that I'll get to very soon. This is an umbrella organization of groups that are also umbrella organizations, and so the group, or the tent, is very small right now. We'd like to enlarge it, but others are not so sure. So it's still, we're doing a little bit of a dance to figure out what exactly this will be, but it's been very helpful for us to have a sounding board in terms of, if we're looking to change things, what do you think, how could this work? And certainly it's been their feedback about advance notice, about needing our input, about consultation, and about our scientific advice process. So challenges, and I have just a few slides, and I don't want you to think that these are all challenges, because I think there's also opportunity here. One of the challenges is ensuring that this is not simply a tick the box. Patient involved, yay, move on. It has to be truly meaningful. This is based on relationships, it's based on trust. It doesn't happen overnight. It takes some time, but it has to be truly meaningful in order to be able to advance this. And so that is one of the things, again, that we explain to our staff. It's not just one step on your Gantt chart. This takes time, and it makes things better. We've also wondered about some clarity in language, and maybe it doesn't matter, but maybe it does. So we've talked about patients versus public versus citizens versus carers versus patient advocacy groups versus patient groups. So I think there's some sense in being able to maybe delineate all of the potential categories, and also think about what role each of those could have, because again, it's not a one-size-fits-all approach. And there's also been discussion in the literature about, what are the levels of engagement. So there's, I want your input, I want you involved, I want you to be engaged, and does it go beyond that? So again, thinking about it in terms of, who gets involved at which stage of the process, for what purpose, and to what extent. I've also mentioned a few times the burden that this can place on our patient groups, and I've heard this directly from them. It's not just me imposing this, but recognizing, again, these people are sick. In Canada in particular, it is a small country, so sometimes these are the same, 3 people preparing many dossiers a year, and it always happens to be over Christmas, so go figure. And then for me as an epidemiologist, I'm concerned about representativeness. So again, whose voice are we hearing? Are we hearing a voice that represents, all potential people on a spectrum of a condition? Or am I hearing from those who might be well enough to participate and have a loud enough voice? So figuring out how to do that, particularly when we have our expert committee meetings in person. So if we're going to have patient representatives on our committees, if they have to be in Ottawa, at a face-to-face meeting and they're not well, how can we use technology to make sure that we're able to get at absolutely, the right people? This is probably the elephant in the room, and I put it up here not to say that this is what I believe, but I believe that there is a strong perception of conflicts because some patient groups receive funding from the industry, whether it's pharmaceutical or device. And again, it is what it is. These patient groups often have no other sources of funding, and so where are they going to get it from? And so as this article from the New England Journal of Medicine just last month suggests, it's about transparency. So, so rather than saying you can't do this, it's, well, who's involved, what are the rules of the game? And so I just put that there as a bit of a reminder, because I know when I'm conversing with people about the importance of engaging patients, this is the thing that often comes up most frequently, and we've got to get past it. If I could, I think this is my last slide, and it speaks to the potential to evaluate the impact of our patient and public engagement activities. And so at CADTH, we've done some by way of evaluation, often tucked into our entire organization's evaluation, which we're subject to every few years because of our funding. But there is a tool, and this comes out from Julia Abelson, based at McMaster University, another Canadian, but it just speaks to the fact that this is important to us, and we've got the right minds thinking about how to do this. As with everything that we do in HTA, I think we need to be critical of ourselves and look back on what we're doing, how we're doing it, and does it make a difference? If it needs to be improved, we need to do that. We're asking everyone else in the system to kind of live up to that standard. I think it's time that we look in the mirror and actually, walk the talk, if you will. With that said, I will wrap up and happy to answer questions after Anna's talk. So thank you.
Thank you very much, Tammy. I will now give the floor to Anna. I forgot maybe to introduce you before saying that Anna is a sociologist and anthropologist, and you've been working on patient issues since 2009, if I understand well.
Yeah.
So you have a long experience in liaising with patients yourself. So the floor is yours.
Thank you. Well, I'm here to talk on behalf of Pedro Serrano also. He's the president of the Spanish HTA network at this moment. It's a rotatory presidency, and he was really, really sorry he couldn't make it today. He couldn't cancel another meeting he had, so sorry. And I'm Ana Toledo. I also work at the Canary Islands HTA services as Pedro, and I'm the qualitative researcher there. And I've been working in HTA for the past 3 years, but as Valentina said, I've been working with patients a little bit longer. Today I'm going to present the patient involvement experience in Spain in HTA. As you will see, we're doing our first step in common procedures. As yesterday was shown, we have a lot of experiences. Agencies have been working a lot with patient involvement for quite a long time, but we are now trying to build a common strategy for the future. This presentation will cover the following themes. What are the main challenges of our network to involve patients in regular activity? What are the strategies and activities that we are doing currently and that we have been doing? I will go quickly through the past activities, as I think yesterday we have a lot of them really deeply by my colleagues really passed through them, so I'm not going to detain myself on that. Which are the key factors in moving beyond goodwill and to real experience in patient engagement, and what are the previous experiences, as also said, and what is a patient, what are we considering as a patient, what do we expect from her, and what programs and services are we going to build to support effective participation. Well, yesterday I think Paloma told us about the Spanish network, so I'm not going to repeat that. First, I would like to say that the Spanish network, it's really committed with patient involvement. We feel supported by our governing body and from the Spanish ministry that recognizes the need and value of active participation of patients to improve decisions in HTA. Patients are considered to have a unique knowledge, experience, and perspective that can contribute in an essential manner to HTA. Making explicit the understanding and applying this knowledge can improve the answer given to patient need, as Tammy has presented just right now. And the objectives of patient involvement in our network are democratization, increasing transparency, responsibility, and sustainability in decision making. The main challenge we have identified, well, I think there are a lot of challenges that we can see all across the network, from technicians to body directors, but I have selected these 4. I think there are many challenges from the everyday work and big challenges for the strategy, but I just wanted to remind these 4. The first one is to increasingly open the network to patient participation in the different activities that we do. The next one is to involve patients in all reports, to increasingly open, not just in one report, but maybe not in individual experience, but as a cross strategy. The next one would be to develop procedures and methodology to improve patient involvement, allowing them to make valuable contributions. And the last one, to inform and train not only patients, but also ourselves as HTA developers and other agents. As they were saying, it's important that it's not only patients that get the education, but also us. We need to improve our skills to be able to, as Tammy was saying before, we had not really that experience. Our view is mainly quantitative in what we're doing currently in our everyday job. So where the views of the patients need to be also, it's not easy, as Yolanda was saying yesterday, sometimes it's not really easy to analyze and to mix the contributions from the qualitative evidence that we are using now and the patient perspective we want to incorporate. What are the facilitators in our network? Well, as we told yesterday, there are a lot of previous experiences. We talked a little bit about them yesterday, so I'm not going to repeat them. Especially in clinical practice guidelines, we talked about yesterday a lot. I would also like to remark that there's also a common methodology that was built here in the LEACS, and that is being used in clinical practice guidelines development normally. We also have a lot of experience in construction, in making shared decision-making tools that patients are actively participating. We have a long experience in the network doing that, and the patient involvement is clear from in all the tools. Then we have a lot of evidence-based products for patients that have been developed by members of the network that try to use common language and try to adapt evidence-based relevant information for patients. And patients, of course, are all actively participating in deciding what must be on those documents, and that they evaluate, assessing them to be readable for them. So that's it. Last year, we don't have a lot of experience in HTA, but we have a few. And please, this is not a complete list, just are the previous experience that I know most. But in Aquas did a report on 2014 that collects all the patient experience in our network. So you can go there to see a full list of experience. But I wanted to talk about a little bit of HTA pilots that we did last year in the Canary Islands. We tried to involve patients in some of our reports, and we did in the blood glucose monitoring device. We had an external reviewer from a patient association who did really who was able really to contribute to some of the aspects of the report, and was really, I think, really contributed to some aspects, especially to add patient perspective and patient important outcomes. And well, it was really a really interesting experience. We also have had a small participation in a neonatal screening procedure program that we analyzed last year, and the patients were also able to contribute, especially in those cases were especially worried about information and communication during the screening process. And well, you can check the report on that. And we also had some failures last year. We tried to, for example, engage patients in prostate cancer genetic test that was trying to just try to improve decisions on how to act on the detection and on deciding in what phase of the cancer to put the patient and what to do with this information. But it was really difficult to find the adequate person. We tried in many organizations. We had contact with cancer patient organization, but finally we didn't have enough time to identify someone that could help us. Even if we identify prostate cancer expert patients, but he could not talk about this procedure, so it was kind of hard. So for us, we have also reviewed our experience. Last year we did some interviews with the HTA unit director and expert patients that have participated in some of these processes, and the HTA perspective on previous patient participation was an overall satisfaction from the members of the agency that have been involved in patient involvement. Really, I think most of the people that I talked to had experiences in patient involvement and were really happy about them and were really looking forward to have more. But there were also some worries as capacity necessities, needs that were identified, and the main worries were what patients to involve. There were a lot of questions across most of the agencies about representativity, as Tammy was saying, and diversity. What patients are being involved? Are they representative or as Tammy was saying, of every patient? And in Spain, there was also this consideration about regional diversity, because our network, one of the main objectives is to identify cohesion problems in the system. So regional diversity was another worry, for example. Another worry that we have also talked about is lobbying patients, conflict of interest, in the sense that some people are still worried about the probable bias of patient experience, but I think it's just a capacity building issue that it can be easily solved with experience. The expert patient perspective was more or less similar. We saw an increase in satisfaction, meaning that patients that were involved a long time ago, like 6 years ago, were not that satisfied. I think because the processes were not still prepared. We didn't have methodologies. We didn't have the capacity that we're currently building. And as Tammy said, my impression is that we must be prepared for making minimum or for receiving meaningful contribution, to know what's meaningful, and to know how to use them and apply them. And the first, some patients felt that they were alone in the processes, that they were not accompanied. But the latest experiences were really successful, or more successful. Patients were really satisfied. They felt they were listened to. They could make changes, especially those in clinical guidelines. They really felt they were part of the process. So I think we're really improving on our capacity. Which is the strategy, the patient involvement strategy we are building here. We started last year with the engagement from the ministry to do a patient involvement methodological handbook. It's already written, it's in review, and it's still a working process, in the sense that some consensus is still to be made, but we're working on it. The methodology we used was a systematic review to review previous experiences in international context on patient experiences, but we also wanted to adapt the processes to the Spanish network and to our procedures and methodology. So we did in-depth interviews, which I already talked about, with HTA unit directors. We did a Delphi with patient organization to consult them, their knowledge and their needs and their expectations about participation. And we also did and are doing a consensus in the HTA Network Council about this strategy. The results of this process was first the methodological framework and tools adapted to a network in which we collected what are the expected contributions of patient involvement. We collect all the possibilities of involvement in all the phases of HTA, all the methodologies. We, as Tammy has already explained, we consider that patient involvement could be, or both of you have explained, could be from the identification of topics, prioritization, to defining the scope and the objectives, to including experience, perspectives, and patient values and preference, and to helping, as yesterday somebody spoke from AETSA, helping from evidence to recommendation, to build a recommendation. We consider a broad range of possible agents to be involved, we have already talked, from expert patient, from individual patients, to patient organization. We are not including broad public, because we are thinking more in starting to build patient involvement in individual reports. So we're considering also users and consumers, maybe, depending on the technology, and also carers, maybe, for some reports, depending on the device that we have to, or product that we have to assess. So, and also we were thinking on a wide range of methodologies that can be used, meaning that we included direct participation in expert panels for reports, but also we were thinking about consultation, systematic reviews of literature, and other consultations that could build on patient perspective for reports. The second result of this process was a proposal of a patient involvement strategy that included short, medium, and long-term action, and was discussed in the Network Council in March 2000, just last month, and we have an agreement on short-term patient involvement, but we still have to discuss the details for mid and long-term strategy. So for this year, we're going to start with a public declaration on the commitment of the network in patient involvement. That I think it's already done. We're going to establish a procedure for patient invitation, selection, and participation to our activities. We would like to have a common procedure that standardizes and opens and makes transparent participation. We're having pilot experience. Most of the units have compromised in involving patients, at least in one of their HTA reports, to do a pilot and to introduce involvement in protocol development, helping to define objectives and the scope of the report. We are particularly interested to include patients in grade methodology, which implies that they identify the main measured outcomes that they expect to be included in the report. Then we are involving them in reviewing the preliminary version of the report, and in the lastly, to contribute to the patient version of the summaries that we are making. I know that some agencies are going to increase participation, to do a little bit more, and some agencies are just involved in this. We are also doing training materials for patients. This year, as most of you have heard in the dinner and in the coffees, we're joining some agencies to build these training materials for patients, documents. We are also planning to do a video presenting HTA to patients and other agents. We have already agreed in a declaration of interest, conflict of interest document adapted for patient participation, taking into account what Tammy just said about that. It's just to be transparent, and then it would be, as we do with other agents, will be judged by the team in charge of the report. And lastly, we're promoting synergies with other spaces for patient participation that are already established in the ministry, as we have a network of health schools for citizenships, and we will network with them to identify patients and see what we can do in common. This is the agreement, and we are also starting them. For midterm and long-term actions, I think they're going to vary, not all in a bad way. I mean, I think some of the actions will be done this year if possible. For example, the second one, training of HTA technicians to improve capacity on patient involvement. If we are able to do, we have a network meeting in November, and if we are able to include this in the meeting, we will try to do it. The first one, we will be extend the scope of patient participation to literature review and other review and other resources to introduce patient-related issues in HTA reports. We plan to do also dissemination activities targeting patients, carers, and users. Last year, during the consultation, we identified that there was a great lack of knowledge among patients among almost all patients in HTA in Spain. I haven't said that, but last year for building the methodological handbook, we contacted with the big platforms, the Spanish platforms of patients who help us in some parts of the report. We also contacted UPATI, who would really provide us with good contacts of expert patients in Spain that were educated with them and who had participated as expert patient, even in the review of documents that has participated as an expert and as an author of the report. So we are starting to build the network, but I think there's a lot of thing to do in dissemination activities for patients' organization to get to know what we are, that we exist, and that we are trying to engage them, and we are really open to their participation. Another dissemination activity could be to disseminate the public allegation score. We are standardizing a public allegation procedure that is open to patients too. And lastly, we would like to do an evaluation on patient involvement in a few years, to conducting a qualitative evaluation and creating a checklist to facilitate HTA developers the engagement of patients in the future. Long-term actions would be extend patient participation to all reports. I think this is a big challenge because of the timely request of the reports, but we're really willing to do it. Modify methodologies and procedures in relation to the evaluation. As Tammy has said, we understand this is a process that we still have to learn and to adapt to our network procedures and methodologies. So we would like to establish an evaluation process that can be continuous or over time. We would like to establish mechanisms to incorporate and document patient contributions in a transparent manner and be able to publish them. That would be nice. We would also like to conduct primary studies to introduce patient perspective when necessary. As we saw yesterday that Yolanda told us, there are devices or programs that are especially lack of evidence, so they're especially sensible, and we would like to introduce primary studies when possible, but this is also brings time concern in HTA reports. We would like to find how to ensure representativity and diversity in patient involvement, and we would like to consider other ways of patient participation in the network activities and structure, and then adapt the current selection and prioritization tools to allow also patient involvement. I know that some agencies, some units are already engaging in some of these activities. For example, they are already opening identification tools to patients and already doing activities to promote this engagement. So I think in a while we could be able to combine experiences and make this happen. And this is it. In conclusion, I think we are committed and feel really supported for patient engagement in the network. We have increasing capacity for effective patient involvement, but there's a long road ahead that we have to drive.
Thank you. So thank you both from your very thorough presentations. Is there any questions from the audience? That for Tammy and Anna and myself, if you have any, I don't know. Yes, please.
Thank you for the brilliant expositions, and congratulations for sharing with us the Canadian experience and how you have so explicit methodologies or way of doing implicating the patients. Hopefully we have also a good explanation of what is happening in Spain. Maybe it's not so explicit and so well done, but I think that Anna has explained very well that things are being doing, even there is not a manual to do that yet, but it is coming. I have a comment precisely to you, Valentina.
Yes.
You mentioned that there is a life cycle of HTA. Excuse me, but I think there is a mixing of concepts. Technology has a life cycle. Technology is coming from innovation, going to regulation, put into the market, and maybe it will be obsolete or not. But technology assessment is a process. It has not a life cycle of technology assessment. To my way of seeing that, I am 25 years working in HTA. I think that there are projects of HTA. Maybe it could be old at some time, but technology assessment as a process is another thing. I believe that patients should be involved in many tasks. In the life cycle of technologies, which is a process which happens in industry, happens in hospitals and many places, and the other is what Anna explained, what should be evaluated or should be assessed. And I think, I believe that patients you have many things to say in identification what should be evaluated, what is the scope of the evaluation, how values of the patient should be included, how to transmit the evidence to decisions made by politicians, by patients, by clinicians, and so on. But the life cycle, is my point of view, is the life cycle of the technology. The other is a project, is a way of doing a process of assessing a technology. Just
Maybe
a comment.
It's just a way of using the wording, but I see the assessment as you said, it's a process that involves several steps and involvement of several actors. That's why I use this word, because it has a beginning and an end with the assessment results. That's why I use this word. Maybe, it's not a major issue if we use it or not, but that's why, that's the way I see it, at least. Any other questions? Yes.
Any of you, congratulations for both presentations. Any concern about the bias of patient selection in terms of how they are selected for participating in these processes?
So it's a great question, and there's been a lot of work that's been going on through the HTA Patient and Citizen Interest Group, and I think in fact they've now spun off I don't want to call it a subgroup, but another group within there to look at methods and impact, because I think many of us who have gotten into this space, particularly from a quantitative discipline, initially when we got going around our patient engagement activities, we were looking to do surveys of large numbers, of course, in order to be representative and do a lot of work on the surveys to make sure that we were asking the right questions in a reliable and valid approach. That takes way too long to be able to fit in with our processes. And the pressure for us continues to do our work even faster than we're doing right now. So for our common drug review and our oncology drug review processes, we have 180 days from receipt of a submission to issuance of a recommendation. So that's not a lot of time to be, sending out a survey to Canadians to be able to get at these, particularly with so many different, potential for so many different surveys to be going out. So I think we've been able to, some of us have been able to move away from that desire for, this needs to fit in with a very quantitative discipline. But I do think there's still that concern about, are we hearing from all of the people we need to hear from? And I think I think there's a lot of work to do in that space. For CADTH, our submissions on the drug side were initially restricted to patient groups. So we right from the get-go said, we can't manage if all patients with a particular disease responded to us. I mean, wouldn't that be great? It would deal with our representative issue, but we wouldn't know what to do with it internally. I should say that our patient engagement team at CADTH is 2 people and a director who also does a few other things. So it's not a large team. But one of the things that looking at those patient groups led us to, particularly when we got submissions for rare disease drugs, was the fact that sometimes there isn't an organized patient group. And so we had to then relax our criteria in order to allow for submissions from individuals. So now we have that ability that it could be a patient group or it could be a patient, but it's still, for people who are scientifically trained, I think it still leaves them a bit wanting in terms of, well, this isn't at the same standard that I'm evidence-wise, but it still is evidence. So I think it's working with groups. And in Canada, we don't have that overarching patients forum like that Europe has, and perhaps this is one of the things that we need to think about in Canada, is just how can we wrap our arms around this and find a way that works for all. I think there's also been a bit of, I guess the flip side to all of this is, again, you're hearing from the patients who have a condition. And so, of course, they're hoping that treatment gets funded. And what you're not hearing from, or who you're not hearing from, are the other patients whose conditions, or not yet patients whose conditions are not for that one drug. So it's sort of the invisible patients whose voices are not being heard in that submission. But of course, those people, maybe they're members of the public, maybe they're citizens, have an ability to engage with the process at sort of the political level in terms of what is the process that you would like to see in order to ensure a reasonable, distribution of the funds that Canada spends on healthcare. And for us, we are at that 50% mark where 50% of our tax revenues are going to health. And I don't know if that's the right number, but it seems to be a bit of a psychological tipping point for people, in that our tax dollars also have to cover off education, environment, defense, and so on and so forth. So to go back to your point, I mean, I don't know what the easy answer is. All to say we've recognized the need to find a way to engage more people, but again, in a way that makes sense and is respectful of not wanting to add burden to an already very complicated life. We've started to have some conversations with colleagues globally and as well as industry who does this. I mean, some of the companies are doing this. They're engaging patients early on in their processes and thinking about a way to share this information. So while, let's say, a patient with rheumatoid arthritis in Canada may have different options than a patient with arthritis here, the condition itself, I would think, if you've got a particular diagnosis, that experience should be similar. And so again, it goes back to, can we share information across borders using, electronic means, perhaps as social media, in order to be able to have almost a repository, if you will, so that people can go there. It would need to be updated, it would need to be refreshed, but could there be I don't want to use the phrase crowdsourcing, but that's sort of, how can we get at this without just thinking about it has to be the way we've always been doing it? Because again, that's that's not going to be allowing us to engage everyone who needs to have their voice heard.
Good morning. I would like to propose some sort of challenge, and if there is any evidence, which I think there is not, and if there is, maybe the Canadians who have more experience on citizen involvement in priority in health, generally speaking, maybe 15, 20 years, no? Ontario or Saskatchewan, etc. The challenge is the following. Let's have two different groups, a serious standard technology assessment outfit, and another one with all the resources to have patient engagement of all sorts without much a priori definition, and compare the results. And if you want, we can bet what's going to be different. We are discussing safety, don't we? We are discussing effectiveness. We are discussing variations of that at this page, 90% of the current technology assessment. 30 years ago, it was supposed to be a device or a molecule-centered technology assessment, a problem-centered technology assessment, and a facility-centered technology assessment. That's not the case. It's supply-sided now. That's where our masters have driven us, all of us, even Canada. Now, that's the challenge, and there is a null hypothesis here. And I want to hear solid reasons against the null hypothesis. Or put it differently, what's the role of patients, say, in the coherent collaboration? And I want to keep it open. Thank you.
That's a great question, and I think Nicholas might be discussing this in the next session a little bit. I mean, it is, for us in Canada, we've, if you go into PubMed, you'll find, articles, there's pockets of activity. But I dare say it's not been coordinated and it's not been sustained. And so, in fact, some of the findings out of the citizens' jury's work have been okay, but again, you found, you've worked with 20 citizens, and so how do you get that spread and sustained through various changes in governments or just, different issues coming forward. So, I mean, one of the thoughts that has been put forward is to find some sort of home, if you will, for various patient and citizen engagement activities. And then could it be funded so that, that perceived conflict of interest over the industry funding could be removed? Could you have a focus within that group on sort of the evidence side, so informing evidence processes, another part being that advocacy side? But again, it hasn't gone anywhere yet. So this is why for us, we and the other HTA agencies in Canada, so again, I don't want you to think it's simply CADTH, but INES, Health Quality Ontario, also have extensive patient engagement activities. And I think it's, the lines are a bit blurred in that they're doing it to help with education. So what is this thing called HTA? And how does it affect you? But also to ensure that the things that we're measuring based on our review of the literature are actually the right things. And so again, that review that we did saying half of the outcomes that mattered to patients were never captured in trials, it's pretty pivotal in that it shows a disconnect in the system. So, I mean, I think the challenge still remains out there is to figure out what is this thing? Where do we draw the lines around this box, because it is getting larger and larger every time I blink. There are now, it's no longer that single technology assessment focus, it's very broad. Suggestions around including environmental impacts in our HTA, so going beyond the traditional clinical, economic, and LC. So just how big does this get, especially when we're one input to a decision-making process that has, all sorts of other reasons. So I like that challenge. I don't have an answer for you yet. But maybe Anna or Valentina want to add to that.
Not much in respect of your question, but when you were talking about patient engagement, it came to my mind as a big issue for patient organizations when it comes to involvement in HTA is resources. So we have to make it sustainable. If you think there is a conflict of interest because patient organizations get private funding, it's because we don't get public funding or not enough to support our activities. So if you want to involve patients, make sure it is sustainable. And I think this is one of the big issues that should be considered when you plan patient involvement also in the Spanish network. Because it's not about willingness to contribute, sometimes it's lack of capacity or lack of resources. So a patient involved in an HTA assessment is a patient that maybe has to take a day off from work and has to dedicate time to this activity. So, or maybe needs education, so you need resources to support these trainings. As patient organizations, we try to fill this gap, educating our patient groups, our communities, but I must say it's a big effort on our side, and it's not always sustainable. It's not sustainable, I would say. So it's really difficult, and we are having discussions now, for example, with UNETA, looking at solutions to overcome this problem. But there's no solution so far.
Yes, but I know that this is a real challenge, resources. It's also, in our experience, the patients' organizations sometimes get really small structures, so it's been difficult. For example, on the Spanish platforms, we reach out to them, but sometimes it's not easy to find them because they have really many activities they are doing in a small structure. So we know that this is a challenge, and we hope that in the future we have a more fluid communication with them. Also, we have worked with many patients' organizations. I think this must be the same in everywhere, that some are really professionalized, but some are really just a few parents or just volunteers that are really new. And we have also experiences with changes in the organization because their democratic processes maybe change their leaders, and then new leaders don't have the experience of other. So it's really, we know that there are a lot of challenges in Fusion. We also, in the methodological handbook, we also consider support to patients, because it's not only about that they know about what HTA is, but that they feel accompanied in the process. Yes. So sometimes it's time consuming for both, for the developers and the organizations.
Is there any other questions from the audience? Because otherwise I would have a question for Anna. Yes, please.
Thank you very much for the interesting presentations. I have a question for Anna, especially for Anna. You mentioned that the questions we made for example, for clinicians, like in HTA reports, for example, efficacy, would be the same, would be important also for patients or users. The question is, what type of questions are relevant for patients in HTA reports?
Okay, I think Tammy has spoke about that with the word, I don't know the name of the cloud. The word cloud. I think in Spain it would be the same. I think patients are interested in reducing their burden, that sometimes that is not included in efficacy measures. There are several studies that study the different point of view from clinicians or researchers and patients. Patients sometimes want just other things like doing common activities that maybe are not included in the Eurocall, for example. Not even the quality of life measures are not always included in the trials that we are judging, and they are also, for example, last year patients were talking about sleeping all night long continuously, for example, or being able not to suffer from puncture, or just the problem sometimes is that are not being informed efficiently, so they don't know how to use the procedure or the device that we're talking about. So they maybe have this device or they're willing to have it, but they have challenges about if they are going to have it, will they be able to use it, for example? Or will they be able to use it in a healthy manner that it's worth for them? I think there, as a qualitative researcher, you can find a lot of different values and perspectives. For example, there's also a debate in patient involvement right now about how to include different values and preference in HTA reports. There's a group that is trying to build a consensus on quantitative measures, for example, and I think your agency is already building qualitative evidence on values and preference, and there is a kind of debate of what kind of values and preference would be represented with each methodology. So, because pathologies are really, really different, and people's need in those are really different. There are also different needs in attention processes, for example. So I think there's a wide range of contributions that can be made by the patient. Please.
Join all the congratulations. Thank you very much. It's been a very, very interesting roundtable. Just abounding on the issue of the burden, and it seems to be like one of the key issues in terms of actually having involvement of patients, and it seems felt on both sides like really critically. So I was really curious, Tammy, about this experience you mentioned, because it sounded really brilliant, of whenever you have you need input about a certain condition or disease, you first review the one you already have,
yes.
So you reduce it for updating. Can you please elaborate a bit more on that? And I wonder to what extent that would be also acceptable, in your experience for the patients, how they feel when instead of going through the same process again, actually they can just review what has been done and improve.
Yeah, no, and so that feedback actually came through our patient liaison forum, and it sort of happened by chance. We received a number of submissions, all within a very short time frame, for different drugs for that same condition. And it might have been hepatitis C, thinking back on the timeline when we were receiving a lot of submissions for those drugs. And so, it was the patient groups themselves that said, we just went through this for drug X 3 months ago. I don't think things have changed. So CADTH didn't make the decision. It was, CADTH going to the patient group saying, we've already got this, thank you very much. If you're good with us using this, we will. So it was that checking with them to make sure that they felt things hadn't changed enough. Maybe if the timeline had been longer, they might have wanted to go back out to their constituents to validate that. But it's sort of that engaging them in that decision rather than us deciding, oh, it was only 3 months ago. Stuff hasn't changed that much. But it's not always that case. So sort of Anna was mentioning, sometimes there are changes in the leadership of groups. Sometimes our groups have merged. So for example, in Canada recently, our Breast Cancer Foundation has merged in with our Cancer Society. So now they're part of one group. And so if we've got those changes, we'd likely have to go back and find out what that process would be. But again, it's interesting, and there is a point I wanted to bring up about us sharing the patient evidence publicly on our website along with the other evidence. And it was interesting because, again, it was a patient group who said, we're very happy that you're doing this because, again, it's a signal that this is, we take this seriously. But the patient group actually said they were a little worried about their ability to be completely frank with us because some of their funding comes from said company, and they were worried that if they didn't speak glowingly about current treatments, that it could lead to a reduction in their funding. So it's almost, there could be unintended consequences of some of this, but again, I think it speaks to the need to move beyond the status quo, and if we really want to get beyond this, we've got to think about supporting our patient engagement activities through other mechanisms. But again, it was that very honest conversation that we were able to have. And again, it was not to say don't post, because again, that's what everybody wants. But it was sort of that recognition of, well, I might not be able to speak so as honestly as I would, because of that sort of fear from the group, the patient group themselves. So it's, yeah.
Thank you. I have one last question myself for Anna about the patient involvement strategy. So you said that it has been launched in March this year?
No, it has been launched in March. The first part, the short term, there was a consensus on the Network Council to engage in this activity for this year.
Okay, and you said there will be pilots. I would be interested in understanding how long the pilots will take, and whether there will be a validation, an evaluation of the pilots afterwards, I guess.
Okay. In Spain, HTA reports are engaged for 1 year, so they are decided in the first month of the year, and then they are conducted along the year till December. So they will be engaged, and we haven't thought of assessing the process of the pilots, but it's a good idea. Maybe we can do that. Yeah. Yeah, maybe in the November, if we finally are able to do the we have a November seminar from the HTA network, and maybe we can share that.
I mean, the Spanish or
the Spanish network joins in once a year for.
And the second part of the question is if you, as a Spanish network, could share the findings with the UNETA, maybe, because it would be interesting to transfer this practice to other member states if it is successful, of course.
Okay.
And
yes, we can talk with the UNETA members of the. Well, I mean, with the UNETA Liaison.
Yes.
With that.
Yes. Okay. Thank you.
Of course.
So, is there any other question? Otherwise, I think we can close here. We have reached, exactly it's 11 a.m. So, thank you everybody for attending this panel.